Good afternoon, everybody. My study is about a comparative surgical comparison between two surgical techniques, that is superior oblique tuck with inferior oblique recession versus inferior oblique anteronasal transposition in cases of congenital superior oblique palsy. I have nil financial disclosure. So even for strabismologists, managing superior oblique palsy is a complex and challenging situation in view of incapacity to examine, especially in cases of children. Then diversity in presentations of SOP. We need to tackle diplopia, AHP, vertical as well as torsional deviations, all in one surgery. So there is, and as such, there is no consensus reached about the best combination of muscles to be operated in a particular case. Yes, yet by von Uden's modification of the NAPS classification, we are either advised to do a superior oblique tuck or a graded inferior oblique recession. But when the hypertropia is like more than or equal to 15 prism diopters, like a large degree of hypertropia, inferior oblique overaction of more than 3 or 4, and a big SO underaction and gross torsion, we have to touch two muscles in this situation. That is, we might have to do superior oblique tuck plus inferior oblique recession. But what if there is a procedure in which we can touch only one muscle and all our agendas can be fulfilled? So we are taking the inferior oblique all the way from its insertion and to taking it beneath the inferior rectus and attaching it at a point 2 by 2 mm nasally and anteriorly to the inferior rectus. So this is the surgical representation of what we actually do. We have disinserted the inferior oblique and then we are taking it all the way beneath the inferior rectus and attaching at a point as shown in the image. So we studied outcomes between Jan 22 to December 24. Group 1 was the traditional IO recessions with SOTUC, and Group 2 was IOANT. We included only congenital SOPs and we with associated or not associated with horizontal squint. We excluded all the associated vertical squint other than SOPs and previously treated SOPs also. We did a detailed squint examination, but our outcome variables were essentially vertical deviation, improvement in AHP, and a fundus torsion. So this is my Excel sheet. We have also found esotropia with many congenital SOPs bilateral. We found exotropia in only one case. Esotropia and exotropia was managed in the same sitting. And the result are as follows. This is an example of a 35 PD esotropia with grade 3 inferior oblique overaction and an SO underaction. And you can see the post-operatively inferior oblique underaction has collapsed nicely, and so is the superior oblique underaction. So why are we having this basically, and what is the physiological funda behind inferior oblique anteronasal transposition? So this is how the inferior oblique direction is post-graded IO recession, and this is how along the neurovascular bundle the position of IO after IOANT. So basically we are turning an extorter into an intorter and an elevator into a depressor. So we can see a very good collapsed inferior oblique overaction and an SO underaction, and also the gross X-cyclotorsion can be eliminated with this procedure. We followed up the patients at the statistical analysis was done at 6 months, and we found that vertical deviation, IO overaction, SO underaction, all were comparable in both the groups. The results were comparable. Yet we found what is significantly we found in the study is the time required in IONT was much lesser than the second group, as we are touching only one muscle in this group. So about the intraoperative complications, we had one patient with consecutive exotropia. In IOANT group, maybe we placed the inferior oblique 3 mm nasal in this situation, which led to exotropia, which was taken care by the prism. So what was already known as large angle superior oblique palsy muscle needs 2 muscle surgery, but it can, and there is also a risk of anti-elevation syndrome and the risk of recurrence and residual IO overaction as well. But an IO anterior nasal transposition had been studied earlier by the many doyens in strabismology. But what we are trying to tell from this study is it can be done in congenital SOP also. It is easy, safe, less time consuming, and equally effective to it, and very effective in tackling large angle inferior oblique overaction, large hypertropias, torsion, and AHPs as well. Thank you.
one question.
Yes,
Have
ma'am.
you done randomization of the patients while choosing in which group those patients
Yes,
will
ma'am.
be?
It was totally randomized, and we purposefully chose only the patients in which we had a large angle of hypertropia, so
Amit
that
Mohan.
That I know.
yes,
Randomization
yeah.
of procedure while choosing the groups.
Yes, ma'am. That procedure was totally randomized between congenital SOPs.
Okay.
How did you randomize? You generated in the computer or you generated it manually? How did you randomize?
So we generated it manually only.
So you, that was double blind. You did not know what the patient had. Amit,
Yeah.
नहीं वो नाम है ना? आजमगढ़ में, ठीक है. Did you do FDT in all the patients?
Yes, sir. Pre-surgically, FDT was done in all the patients. Yes, sir.
You felt that supraoblique was very high.
Yes, only those cases.
Did you get any MRI done to see whether the supraoblique, classically the congenital supraoblique patients do have a very thin supraoblique? Do you find any of the patients where you were planning to do a tuck and you felt that supraoblique was actually missing and you could not look at? There was no such patient?
No, sir. This particular thing we did not find in any of the cases. Thank you, sir.